Let's discuss about anti-tubercular drugs. So we know the first line drugs of tuberculosis is Isoniazid, Rifampicin, Pyrazinamide and Ethambutol. So these are the four drugs in the first line. They are given as a fixed dose combination drugs. Okay. Now there are other drugs, the supplementary drugs like streptomycin. It's in injectable form. Rifabutin, Rifampicin. Okay, this is a supplementary drugs for anti-tubercular therapy. Now the second line drugs includes thioacetazone, PAS, cycloserine, kanamycin, amikacin, capreomycin, ofloxacin, levofloxacin, moxifloxacin, linezolid and clarithromycin. Okay, so these are the drugs for the anti-tubercular therapy. The other drugs for like the for the resistance which is developed are bedaquinyl delaminate, proteomanate. We will discuss in the later part. Okay, now so the first line drugs, earlier it was 5 drugs, but now it's just 4 drugs. Okay, so 4 drugs. The streptomycin was removed because it was injectable, and we are like giving the fixed dose combination of all the drugs of the first line, so we have to remove the streptomycin. Okay, now here the first drug isoniazid. Okay, so the basic agar dekha jaye, so what is, like, suppose there is isoniazid. Okay, there is pyrazinamide, okay, there is ethambutol, and there is rifampicin. ठीक है, अब मैंने ऐसा क्यों लिखा? See, this is RIP. okay, so rest in peace किसका? Actually liver. So there is a liver damage in all three. Okay, ethambutol E leads to eye damage. Okay, leads to optic neuritis, even color blindness you can say in some people. Okay, but main is the optic neuritis, that is the aim. Now liver damage is there in all the three. Okay, what are the other features in rifampicin, isoniazid and pyrazinamide? Pyrazinamide increases the uric acid and damages the liver the most. Okay, now in rifampicin there is reddish orange, discoloration of tears, saliva and urine. Okay, in the isoniazid there is decrease in the vitamin B6 levels. Okay, so it can cause peripheral neuropathy. Hence we have to add vitamin B6 when we are giving anti-tubercular therapy. Okay, so isoniazid, so it is actually a prodrug which is activated by catalase peroxidase, that is the CAT-G enzyme. Okay, this is the CAT-G enzyme. Okay, so now this enzyme actually inhibits now what it does ki, so isoniazid is activated by the catalase peroxidase, that is the CAT-G enzyme. Okay, now it inhibits the enzyme ketoenol reductase. Now this is based for the this gene INHA. Okay, now isoniazid is bactericidal, it rapidly multiplying bacteria को वो ख़त्म करता है. ठीक है, now very important, it's effective against the intra and extracellular mycobacteria, both intra as well as extracellular. Okay, now one thing that ketoenol reductase, that INHA gene code, it actually inhibits the mycolic acid synthesis in the TB bacteria. Okay, now Now, this isoniazid is most effective against the rapid multipliers, most effective under the rapid multipliers, as well as the bacteria which goes to the brain. So it has a maximum CSF penetration. Okay, so if there is TB meningitis, the first drug to be given is always isoniazid we have to give. Okay, if there is rifampicin resistance or whatever, we'll discuss later, but the first drug is always in TB meningitis is isoniazid, the drug of choice, right? Now acetylation can be done, for the like metabolism of isoniazid. It may be fast or it may be slow. Okay, so in high dose there is fast metabolism. Okay, and in slow there is in the low dose. Okay, there is slow metabolism. So in high dose, fast acetylation causing hepatic failure. It may cause hepatic failure, hepatic injury, and in low dose, it's slow acetylation. It causes peripheral neuritis, inflammation of the peripheral nerves. Okay, so the treatment basically where it is given in TB for prophylaxis, TB in pregnancy, and MDR latent TB. Okay, now there is a resistance caused by the CATG mutation, catalase peroxidase mutation. Okay, so there is the first mutation causing the resistance, and the second is the INHA mutation causing the ethionamide resistance. ठीक है, तो यहाँ से MCQ आते हैं, this you have to understand. The side effect is peripheral neuritis. As we have discussed, we have to give pyridoxine, vitamin B6 pyridoxine we have to give. It also causes hemolysis in G6PD deficiency patient, causing the hepatotoxicity. Okay, it has also a MAO-A inhibitor. It causes the cheese reaction. Okay, it causes rash, fever, anemia, optic neuritis. We know seizures can be seen. Okay, gynecomastia can be seen. Okay, psychosis. It is very important. Parameter for very important side effect and parameter to see how the anti-TB is actually working in a particular patient. Okay, there may be memory loss and can cause a lupus-like syndrome, SLE, systemic lupus erythematosus, lupus-like syndrome. Okay, so these can be asked in Viva. Like, what are the side effects of peripheral neuritis? What is the side effect of isoniazid? It is the peripheral neuritis. Okay, next, rifampicin, very important. It is the bactericidal drug. It is acting on the dividing and non-dividing TB bacteria. Okay, it inhibits the DNA dependent RNA polymerase. Okay, now it has an enterohepatic circulation and liver metabolism, so it has a frequent tendency to damage the liver. Okay, now it is safe in renal dysfunction patient. It is excreted in the feces. It is safe in renal dysfunction patient. Okay, orange discoloration of all the secretion like tear, saliva, sweat, as well as your urine. It is given empty stomach. Now the TB drugs are basically given in empty stomach just because use of rifampicin. Okay, now both intra and extracellular, and it penetrates the blood-brain barrier. It acts on both intra and extracellular TB bacteria, right? Now it is effective and it is fastest acting on the leprosy bacteria also. TB का भाई leprosy, ठीक है, Mycobacterium lepri. Okay, so it is acting very fast on the leprosy bacteria. Okay, now the side effect, it is the proteinuria, it is hepatotoxic, rash, flu-like syndrome, anemia. Okay, so increase in the bilirubin without the SGPT elevation is caused by the rifampicin. So when we see the LFT of the patient, liver function test, we see increase in the SGOT and SGPT of the patient with increase in the alkaline phosphatase. ठीक है, alkaline phosphatase, very important. So we have to give liver supportive treatment when we start the TB drugs, and we have to tell the patients to go and check for every monthly you have to check the liver function test. Okay, now it is rifampicin is a enzyme inducer, so patient on warfarin is shifted to the unfractioned heparin. Okay, so the patient on warfarin shifted to unfractioned heparin. Okay, now PAS was there, para-aminosalicylic acid was there in the TB drug, but when it is given with rifampicin, it delays the absorption of rifampicin. It is very important drug interaction. Okay, now AIDS, suppose in AIDS there is decrease in immunity which causes the TB. Okay, here we give rifabutin. It is the less drug interaction is there. Okay, all the with the AIDS drugs. Okay, now rifamycin is given in the treatment of traveler's diarrhea, nothing to do with TB, given in traveler's diarrhea. So the name is important: rifabutin, rifampicin and rifamycin. So rifamycin is treatment of traveler diarrhea. Rifabutin is given with AIDS and with TB, which interact very less with the AIDS anti-AIDS treatment, anti-HIV treatment. Okay, now pyrazinamide, it only acts on the intracellular TB bacteria, right? Now it is bactericidal. Again, all the drugs are bactericidal except the ethambutol. Ethambutol is bacteriostatic. Okay, now pyrazinamide most active against the slowly replicating bacteria and in acidic media. Okay, so it acts on all the inflammatory sites, the intracellular sites. Okay, now it is having the best sterilizing activity. The T half is prolonged in case of hepatic and renal impairment, most damaging the liver, सबसे ज़्यादा डैमेज करता है. Now 40% causes the non-gouty arthralgia. ठीक है, it increases the uric acid also and it causing the pain. Okay, so there is hyperuricemia and causes the non-gouty arthralgia. Okay, porphyria can be seen, photosensitivity also can be seen, hepatic dysfunction is there. So H2P2, there are two: hyperuricemia and hepatic dysfunction, and porphyria and photosensitivity. It is there in the pyrazinamide. Now ethambutol is only bacteriostatic drug in the whole of the 4 anti-TB drugs. It inhibits the arabinosyl transferase. It is an anti-metabolite, arabinosyl transferase. Okay, there is no CSF distribution. Very, very important. There is no CSF distribution. It is dose dependent, and optic neuritis can be caused, which is reversible. Okay, this also cause of loss of color green, so red green color blindness. So there is a green color deficient, so it is causing the dose dependent reversible of optic neuritis. Okay, now it is avoided in children. In case of children, it is avoided. Okay, now it affects the amacrine bipolar cells of retina. It affects the amacrine or bipolar cells of retina. Again, it causes peripheral neuritis and hyperuricemia like other Isoniazid and pyrazinamide, but they are very less. Okay, the more is the I1, the optic neuritis. Okay, dose adjustment is required in case of renal failure. Okay, and there is no hepatotoxicity, very, very important MCQ, and acts on both intra and extracellular TB bacteria. Okay, so this is very important ATT, very important part of ATT. Okay, now streptomycin, this will be what it is given IM injection. Okay, IM injection, injectable form. It acts, it is a we say this is a tuberculocidal aminoglycoside. So which aminoglycoside is used for TB? So that's the streptomycin. It's poor plasma bound. The T half is prolonged in case of renal failure. It is non-hepatotoxic. It is contraindicated in pregnancy. Again, for the all ATT drugs, all four of them can be given in pregnancy, but not streptomycin, right? That's why it was removed from the first line. It acts only on the extracellular bacilli, only on the extracellular bacilli. Okay, it is also non-hepatotoxic. It is also non-hepatotoxic. Okay, so there's a concept of where it is working. Suppose the Z is the pyrazinamide, R is the rifampicin, and H is the isoniazid. So isoniazid act on the rapid growing, rifampicin act on the spurters, and the pyrazinamide act on the slow growing bacteria. Okay, now the second line agents. The second line agent, we have done the first line and the special ones. Now the second line agents, thioacetazone, it's actually a bacteriostatic drug, causes hepatitis. Okay, and the most important thing, the causing of an ADR called the SJS reaction, The PAS is again static. Okay, so it's given when there is a kidney or liver, it causes a liver or kidney damage. Okay, and some thyroid dysfunction as well. Okay, now ethionamide is again very bacteriostatic, causing optic neuritis and hepatitis as well as hypothyroidism. Cycloserine is causing neuropsychiatric effects, Kanamycin, again, it's in MDR. In MDR TB, kanamycin is used. Okay, now capreomycin polypeptide, kanamycin is autotoxic and nephrotoxic and decreases the potassium and magnesium levels used. So injectable kanamycin very commonly used by quacks also. So it's actually a reserved drug, but you have to understand that it is given in MDR TB. It is reserved for the MDR TB. Now ofloxacin, levofloxacin and moxifloxacin, it is given in the Mycobacterium avium complex in case of AIDS patient. Okay, so this is very important. The fluoroquinolones are used over here. The macrolides are given in the atypical mycobacteria. Macrolides are given. Okay, now the rifampicin and rifampicin again, rifampicin very important. It has no microsomal induction. The GI side effects are there, but the 3 P's are very important: polymyalgia syndrome, pseudo jaundice, pancytopenia. Okay, so this is about rifampicin. Not so important, but still you have to understand it. This is maybe for undergraduates it's not so important. For MCQ point of view, it's very important. Rifampicin, it is lipophilic and longer acting. Increases relapse rate in HIV. Okay, so it is absorbed well in the fatty meals. With the fatty meals, it is very good absorbed. So griseofulvin is also absorbed very well in fatty meals. So here I have just compared. Now bedaquinyl, Mycobacterium ATP synthase inhibitor. It is actually the drug of choice for MDR TB, but causes the QT prolongation. There are 2 other drugs, nitroimidazole, mycolic acid synthesis decreases. It is used in extreme resistant TB, XDR TB, also causes QT prolongation. Again, pretomanid is what? Nitroimidazole, decreases the mycolic acid synthesis. Okay, now this is very important question, is BPAL regimen. What is this BPAL regimen? This BPAL regimen is given for MDR XDR TB. The BPAL regimen is used for MDR XDR TB, and bedaquinyl and protimanid and linezolid, this is BPAL. Okay, L, right? So BPAL regimen is for MDR XDR TB, and there is an ADR, that is the QT prolongation, hepatotoxicity, and bone marrow suppression. Now, BPAL regimen can be asked in a 2 marks question. What is a BPAL regimen? You have to just write the names of the drugs, where it is given, and what are the side effects, which you can see collectively see. Okay, and then is something called NTPE guidelines. NTPE guidelines. Okay, now here what is done. Okay, this is very important. You have to understand the all the regimens, how they are given. Okay, right. See, this MDR regimen, this NTEP guidelines. I think BPAL regimen is clear. Now you see NTP guidelines. Drug sensitive TB, new or old patient, the drug is given for 6 months. 2 HRJD plus 4 HRE. What do you mean by that? There is very important, for 2 months. For 2 months, we are given a combination dose of HRZE, Ethambutol, Pyrazinamide, Rifampicin, Isoniazid. Okay, these are the shortcuts. So intensive phase for 2 months, then we remove the pyrazinamide because it was causing liver damage, and we give for continuation for the 4 months. So there is a 6 month duration for the drug sensitive TB. Now, drug resistance TB, as per WHO guidelines 2021, the INH resistance we give RJD. Okay, because isoniazid is resistance, we add levofloxacin for 6 months. We add levofloxacin for 6 months. For MDR or rifampicin resistant TB, there are 3 regimens. For MDR or rifampicin resistance, we have 3 regimens. So in the INH resistance, we give levofloxacin. We add levofloxacin and remove the isoniazid. But in the MDR TB or the rifampicin resistance TB, there are 3 regimen, and the first short regimen plus bedaquinyl, what is given, that we in the intensive phase we give in high dose we give isoniazid in high dose. Okay, Z is the pyrazinamide, E is the ethambutol, levofloxacin, clofazimine, ethionamide. Okay, this we are giving for 4 months. This we are giving for 4 months. Okay, so the continuation phase is all same except the bedaquinyl is added. The bedaquinyl is added for 6 months, and high dose of isoniazid and ethionamide is removed. Okay, this is not easy, I am telling you. This is for 9 to 11 months, and this is short regimen plus bedaquinyl regimen. This is the first regimen which we give. The second, the longer regimen for the MDR TB is the 3 group ATT. The 3 group ATT, there are 3 group A, group B, group C. In the group A, there is levofloxacin, bedaquinyl and linezolid. In the group B, there is clofazimine and cycloserine. And group C, there is ethambutol, pyrazinamide, delamanid, amikacin, ethionamide, pretonamide, PAS, imipenem, celastine. Okay, so there are 3 groups. So 3 groups ATT can be given, right? Now, the third one, the MDR or rifampicin resistant TB, 6 to 7 months of what? Bedaquinyl, linezolid, levofloxacin, clofazimine, okay, all group A, okay, plus 1. And for 6 to 7 months of this, then 2 months of other regimen, that is the linezolid, levofloxacin, clofazimine, right? And but this is a bit confusing, but I am telling you that forget about this, just remember these two. Okay, so in the drug sensitive, what we give, the drug resistance, what we give, the INH, what we give, the MDR rifampicin one, we give this one. Most commonly we give this part. Okay, the longer regimen we divide in the 3 groups, and with the groups we give the, it's very complicated a bit, but you have like while practicing, doctors actually forget for the new regimen and all. So one thing is very important, that whatever it is a notifiable disease, TB is a notifiable disease. So whenever we get a TB patient, we don't treat. Okay, even the drugs will not be there in the normal chemist shop. Whatever the notifiable disease, so we have to report it to the nearest Sadar hospital, nearest other hospital or medical college. Okay, and from there what happens, there they get tested again. They get tested, and why tested? They get treatment. They get treatment with money. Treatment with money. Okay, for money for the good food and habits. Okay, so again the BPAL regimen for MDR TB, suppose resistance to the fluoroquinolones, we give bedaquiline, linezolid, pretiomanide for the 6 to 9 months. 6 to 9 months, and there are other MAC infections also, avium complex. Okay, so I believe CD4 count was not relevant, but for the MAC infection, I think clarithromycin is given. Even the REC regimen is given. Rifampicin plus ethambutol plus clarithromycin or azithromycin, the REC regimen. But I don't think this is important for now. It will be important when you are doing your PSM and other things, right? Not so will be asked right now. Okay, for suppose you have an exposure and you have to give TB prevention. So again, there is a 6 month regimen. We give INH. Okay, or the high dose of isoniazid with rifampicin we given. If any contact is there, drug sensitivity is there, we give TB prevention. Okay, and suppose also there is, if drug resistance is there, so if suppose RE resistance, so high dose of isoniazid is given. Okay, for 6 months. If suppose there is isoniazid is resistant, so 4 months of rifampicin is given, and suppose there is fluoroquinolone sensitive is there, so 6 months of levofloxacin is given. Okay, so this is very extensive. I am not telling you to just go through like very extensively. Just study whatever you can remember. Okay, at least for BPAL regimen is important. Your normal, like if the MDR TB is in a short note, if even you write the delamanid and pretomanid and bedaquiline name also, and some QT prolongation, people will understand that you know the basic concepts, right? So don't go for very hi-fi things, because it's only for your MCQ preparation. But right now I'm just focusing on the like second year and just the third year people, where you have to study a lot about anti-tubercular drugs. So I believe this particular like video will help you a lot. Okay, thank you.